Talking about advances in genitourinary oncology, we're going to be focusing on prostate and bladder cancer. First, let's talk about bladder cancer. As we know, neoadjuvant chemotherapy is the standard of care for those patients who are cisplatin eligible. And as we see from this particular slide, with platinum-based therapy, there is a modest reduction in the risk of death, 14%, for those patients who are treated with either MVAC or gemcitabine and cisplatin. There have been advances in this area using immune therapy with adjuvant therapy post-cystectomy, but of course we want to improve our frontline therapy for neoadjuvant chemotherapy. So this is the Niagara study. This study took patients who were cisplatin eligible, and we'll talk about some other trials that are going to be going forth with cisplatin ineligible patients. And these patients were randomized to receive either gemcitabine cisplatin or gemcitabine cisplatin plus durvalumab. And if they were on the durvalumab arm, they were eligible to receive adjuvant therapy. Now, when we look at the design of this trial, it's a little bit different than what the standard practice is at this point, because for those patients who receive platinum-based chemotherapy and have residual muscle invasive disease post-cystectomy, the standard is to give either adjuvant pembrolizumab or adjuvant nivolumab for a year. So only about 3% of patients in this trial received adjuvant checkpoint in the control arm. So that's a problem right off the bat. So these are the patient characteristics, predominantly those patients having high levels of PD-L1 expression. We also see that regional lymph nodes were involved in about 5% of patients. The patients who were greater than T2 disease comprised about 60% of all patients. So this is an advanced group of patients. So pathological complete response. Pathological complete response has been felt to be a indicator of overall survival. We saw that in the SWOG trial for those patients who achieved a pathological response with MVAC. The 5-year survival was 85%. We see here, this is a reanalysis, 37% of patients in the experimental arm versus 21% of patients in the control arm had a pathological complete response. So overall, right off the bat, we see that there's an improvement. If we look at event-free survival, there's a hazard ratio of 0.68 in favor of the triplet therapy. If we look at overall survival, the hazard ratio is 0.75, or a 25% reduction in the risk of death compared to standard of care gemcitabine cisplatin. So adverse events, this was fairly well tolerated. There really didn't seem to be anything in terms of synergistic adverse events when you combined GemCis plus durvalumab compared to GemCis alone. We see that there may be more rash, there may be more diarrhea with the combination therapy, but all in all, fairly well tolerated. So one of the unique things that was done in this particular study was to look at markers to determine whether patients have poor prognosis and how we could also stratify patients based upon their circulating tumor DNA. So 57% of the patients had sufficient samples of circulating tumor DNA. 58% of those were in the durvalumab arm and 55% in the comparator arm. If we look at the expression of circulating tumor DNA, it goes down from 55% in the comparator arm to 26% after neoadjuvant therapy. There's a greater reduction in the triplet therapy from 58% to 19%. And then post-radical cystectomy, it seemed to be about the same across the board. So if we look at the circulating tumor DNA at baseline, this was prognostic for event-free survival. As we see on the left, circulating tumor DNA negative patients did better than those who were positive. If we stratify that out by the different groups of patients receiving either the triplet therapy or the standard of care, we see there is a separation in favor of those patients who had low circulating tumor DNA levels at baseline. Clearance was also important in terms of prognosis. Clearance of circulating tumor DNA was higher in the durvalumab arm and was prognostic for event-free survival. So again, this is something that we can use to determine further therapy in our patients, and clinical trials are now being designed to look at this particular question. We have a trial open at Yale, it's called Modern, and it's looking at circulating tumor DNA and determining whether a patient should receive adjuvant therapy after cystectomy. And then it was also prognostic for disease-free survival post-cystectomy. So what are the questions that are raised by Niagara? Do patients who achieve a pathological complete response need adjuvant treatment? And that's, I think, a big question. And I think that, of course, that's important in terms of toxicity, in terms of healthcare dollars. So standard of care right now is not to give neoadjuvant therapy if a patient has a complete response, but patients in this trial did receive it. And then what's the role of dose-dense MVAC? It's been seen from randomized trials that dose-dense MVAC does seem to be a superior regimen to gemcitabine and cisplatin. And of course, where do we look at this particular combination in the neoadjuvant state? There are some phase 2 studies that have looked and shown an improvement in overall survival with dose-dense MVAC, but those aren't comparative when that's combined with a checkpoint. But again, we also need to see this. And of course, also the sequential nature of this. Can we get the same results by doing neoadjuvant therapy and then adjuvant therapy afterwards, rather than using all of your checkpoints up front? Another trial that was presented, an update at ASCO in bladder cancer, was EV302. As you know, EV302 is a randomized study that compared enfortumab vedotin combined with pembrolizumab to gemcitabine cisplatin or gemcitabine and carboplatin. This study took both cisplatin eligible as well as ineligible patients. We know that enfortumab vedotin is a smart bomb. It delivers chemotherapy directly to Nectin-4 positive cells, and it delivers a chemotherapeutic agent called MMAE, which does have anti-tubulin effects. And the original trial that looked at EV-pembro compared to standard of care chemotherapy demonstrated a doubling of the median survival in patients treated with this combination. So is this durable? This is further follow-up from the EV302 study. As we see, the objective response rate was 67% with the combination, and 30% of patients had a complete response. That's compared to 14.3% of patients treated with GemCis or GemCarbo, and the objective response rate overall was 44%. So that's a doubling in the complete response rate, and that does translate into a survival benefit. If we look at the duration of response from an independent review, all responders in the EV-pembro arm, we see that the median survival is 23 months, and for those patients who receive chemotherapy, it's 7 months, the duration of response. So the duration of response is obviously almost triple in those patients who received EV-pembro. So if we look at the duration of response versus platinum eligibility, says we know cisplatin is the standard of care for frontline therapy in patients who are eligible. There's been some thought that carboplatin is an inferior drug in this particular situation, and we always try to use cisplatin-based therapy up front. If we look again at the duration of response, it's triple for those patients who have cisplatin eligibility, 24 versus 8.3 months. And again, for those patients who are ineligible, it's about the same, 21 versus 8.8 months. If we look at the best response, the duration of the complete response, this is really impressive. At a median follow-up of 2 years, 74.3% of patients maintained their complete response overall, and that's certainly superior to chemotherapy by itself. And the median duration has not yet been reached, and it was approximately 15 months with chemotherapy, and that's again consistent with what we've seen with prior data. Safety. As we know with enfortumab and pembrolizumab, the things we worry about are rash, peripheral neuropathy, hyperglycemia. And then the question is, does exposure make a difference in terms of response? And do we see any differences in terms of toxicity? Skin toxicity is usually early, within the first 2 to 3 cycles. Neuropathy occurs later, and this, of course, becomes problematic in a patient who has a complete response. So the median number of cycles that were given in patients who had a complete response was 30. Overall population, the overall number of median cycles administered was 12, and in 19 in those patients who had a partial response or a complete response. So more treatment, better response. That's obviously, it's a selection factor, but that makes management of toxicities all that much more important. And again, as we move out in the course of disease, we see that there tends to be more neuropathy. The median number of cycles that patients start receiving peripheral neuropathy is 6, and that requires dose reduction or skipping doses in that particular situation. And as we see from this particular chart, toxicity does seem to be greater in the responders over time. EV-pembro leaves us with another question as to what do we do in a patient who has progressed and we don't have any standard of care. This is some retrospective data that Jonathan Rosenberg presented from Sloan Kettering. And what he did was he took those patients who received prior EV-pembro and progressed and then treated them with either cis or carboplatin combined with gemcitabine. As we see, the median survival is about 11 months overall for those patients who are treated with this combination, and progression-free survival is about 6 months overall. So there is activity, but we are looking at clinical trials. Right now, we have a very novel agent that targets PPR gamma. It's called FX909, and we're looking at that in the second-line situation. In prostate cancer, the most, I think, important study that was presented was by Dr. Attard, which is the Amplitude trial. It's for hormone-sensitive patients combining niraparib plus abiraterone and prednisone to standard of care in metastatic disease. These are, again, hormone sensitive. We know that about 10 to 20% of patients have DNA repair mutations with metastatic prostate cancer. And this trial took those patients who had BRCA mutations, CHEK2, FANCA, PALB2, RAD51B, RAD54L, and amongst others, and randomized them to receive niraparib plus abiraterone compared to placebo plus abiraterone and prednisone. They were allowed to have docetaxel chemotherapy in addition, so actually it's quadrupled therapy for some patients in this situation. And the primary endpoint was radiographic progression-free survival. So as we know in the castrate-resistant state, there is a difference in outcome in those patients who have BRCA mutations versus those patients who have other HRR mutations. So we see here from this particular slide that the hazard ratio, looking at radiographic progression-free survival, was 0.52 for those patients who are BRCA mutated. For those patients who were not BRCA mutated but had other, actually this included the BRCA mutated patients as well, for all the mutations, it's 0.63. So the question is this hazard ratio being driven by BRCA? And that's something we've seen with some of our trials that we've done here with progression-free survival, that BRCA is the major component that drives the survival. And then as we look at the different forest plots, unfortunately the numbers are too small to really look at any particular mutation. BRCA, of course, was the most common, but CHEK2 does seem to track along with BRCA. FANCA, PALB2, those seem to be more either towards a hazard ratio of 1 or actually a worse hazard ratio. So subsequent therapy. One of the critiques of this trial was that a lot of patients who progressed on niraparib who were BRCA positive did not receive PARP inhibitors. And this may be related to the international nature of the study, that they may not have been able to receive other treatments because they was not commercially available or not approved in their individual countries. But again, if those patients who discontinued treatment, 11% in the niraparib arm received a PARP inhibitor, 36% in the control arm received a PARP inhibitor. And this may have an effect on the overall survival. Treatment-related adverse events, as we look at this in terms of grade 3 and grade 4, as one would expect, 75% of patients had a grade 3 or grade 4, and 59% in the control arm. So Amplitude concluded that it met its endpoint of radiographic progression-free survival, and likely the greatest impact was in the BRCA patients, and that improvements of PFS may show an overall survival trend, or at least benefit of survival in the future, and the safety was consistent with what we've seen with previous combination trials with PARP inhibitors. Finally, a study that we were involved in at Yale, the ARCHES trial, which looked at early enzalutamide in patients with metastatic hormone-sensitive prostate cancer. Patients were randomized to standard of care plus enzalutamide versus standard of care alone, androgen deprivation therapy. And we see that at 5 years, the overall survival benefit of using early enzalutamide was maintained, 25% reduction in the risk of death. So again, all patients who have hormone-sensitive disease need to be offered early anti-androgens, The discussion about chemotherapy needs to go forth as well, and that's debatable. And of course, we now will have PARP inhibitors and perhaps radioligands as well to administer in this situation. So in conclusion, gemcitabine, cisplatin, durvalumab is a standard of care for neoadjuvant therapy for muscle-invasive bladder cancer. Circulating tumor DNA can be used to identify patients at high risk for relapse post-cystectomy. Further follow-up demonstrates that the survival benefit of enfortumab pembrolizumab is maintained. The results of the Amplitude trial will move genetic testing in metastatic prostate cancer to the hormone-sensitive state. This is something I cannot emphasize more. Only about 40% of patients with castrate-resistant disease are getting tested genetically in the United States, and this is a must. And the same thing with anti-androgens. Only about 40 to 50% of patients are receiving anti-androgen therapy in the hormone-sensitive state. We need to do better and find out the reasons why, but still we see that the survival benefit is maintained with more than 5 years of follow-up with enzalutamide plus ADT. Thank you for your attention, and I'll call the other, I guess we can take a couple of questions right off the bat, or what would you like to do, Rick? Sounds good. Why don't we bring the panel up and we'll talk about our questions. Thank you. So, sorry? 20 minutes? Okay, great. Fantastic. So Dr. Brito has got his case presentation, so we'll get him to start off. How are you? Good to see you. Thank you. Thanks. So, why don't you, I'll turn the podium over to you. Sure. Do your case.
Thank you. All right, good morning. Thank you for the opportunity to present. So we'll present a case, a GU cancer case. We're going to focus on bladder for our case here, and then Dr. Hicks and Dr. Matera can discuss the nuances of the case as well. So we present to you a 62-year-old male. This is a man who presents to our clinic with complaints of gross hematuria and irritative voiding symptoms. A nice rugged smoker type, which is fairly unfortunately typical for this patient population. So this man has a past medical history of hypertension, anxiety, and hyperlipidemia. He's had an inguinal hernia repair in the past and a 25-pack year smoking history, social drinker. He's married and remains sexually active. His workup consists of office cystoscopy, which demonstrates this finding, which is fairly typical for a papillary urothelial carcinoma. In his case, it's a unifocal, about 5 centimeter papillary tumor. He undergoes staging scans, CT scan with and without contrast, which demonstrates no metastases, and subsequently has his tumor resected, which reveals high-grade urothelial carcinoma, which is invasive into the muscularis for a stage of pathologic T2 disease. As we, I think, know in these cases, the standard of care for many years has been neoadjuvant chemotherapy followed by radical cystectomy, or in this patient's case, cystoprostatectomy. A more recent alternative has become maximum re-resection of the tumor, TURBT, with concurrent chemoradiation to follow, the so-called trimodal therapy. In some patients' cases, partial cystectomy may be appropriate, although these are fairly select patients with unifocal tumor in a favorable resectable location. In a much less favorable option would be cystectomy alone or radiation therapy alone, which are generally not recommended if there's any alternative for the patient. Part of the reason there have been a lot of interest in alternatives to cystectomy is quite a morbid operation. So first of all, we need patients to be fit for surgery. This is about a 5 to 6 hour operation, although in many cases it can go a lot longer than that. These days, these surgeries are increasingly done robotically, which requires the patient to be in pretty steep Trendelenburg position for the majority of that time. So many patients simply can't tolerate surgery. We need to consider chemotherapy recovery in these patients, so ensuring that anemia, thrombocytopenia, and any impact from neoadjuvant chemotherapy on renal function needs to be considered, specifically when we're considering urinary diversion in these patients. And then, of course, resectability of the tumor in higher locally advanced disease. We've seen significant downstaging with some of the immune checkpoint inhibitors, but in some cases, we still can't simply take these patients to surgery.
Can I just interrupt for a second?
Please.
I think what involve the panel in this, I think great case. This is something we normally see. So, Rob, Dr. Matera, what is your frontline therapy for neoadjuvant treatment, and what are you using right now?
Yeah, so I think we'll get into this, but I think it's still up for debate. I don't know if there's definitely one single neoadjuvant treatment that is the standard of care. I would say you have a couple options, either the Niagara regimen with durvalumab, Gem-Cis, but I think DDMVAC and Gem-Cis alone also are still relevant in here.
What are your criteria for selecting either DDMVAC or going forth with Gem-Cis Durva? Do you have an algorithm?
Yeah, I would say, I will say DDMVAC is a little bit more difficult of a regimen to get through. It's 4-agent chemotherapy. It's given every 2 weeks. However, like Dr. Petrylak said, there is evidence that it actually might be superior to Gem-Cis. So in a patient who is robust, perfect kidney function, that's someone you might want to push with DDMVAC. People who are a little more frail, maybe borderline kidney function, that's probably where I err towards a Gem-Cis-based regimen.
Terrific. Dr. Hicks, so you have a patient coming in with radiation therapy. Which patients are you selecting for potentially primary radiation therapy in this situation?
Yeah, so, or maybe I could move on to the...
Sure, yeah.
So, sorry about that. So yeah, we can pull up the next slide actually. But yeah, so this is, often the first question we ask when we have a bladder cancer come in, bladder cancer patient. So of course, there's patients who are medically inoperable, where cystectomy is really not a good option for them. So bladder preservation with trimodal therapy is certainly a good option for those patients. And in some of them, they're not chemo candidates either, and then in which case we're talking about radiation alone. But then there are operable patients for which bladder preservation is also an option. And so there's not a lot of randomized data, but there's been a lot of studies over the years that have sort of focused in on the most optimal patients for bladder preservation. So mainly we're talking about T2 to T3A, and really that means the patients that don't have gross extravesicular extension outside of the bladder. We know that those patients do better with trimodal therapy. Unifocal as opposed to multifocal diffuse disease throughout the bladder, and really that's just because there's more opportunity for local recurrence in the bladder after chemoradiation. Smaller tumors do better. And then, yeah, no extensive carcinoma in situ. We do want the bladder function intact because if they don't really have good bladder function, then there's not so much of a benefit of preserving the bladder as opposed to taking it out. And then one thing we always look at is if there's any hydronephrosis, and there's data showing that patients that there's lower complete response rates and lower local control rates when there's patient coming in with hydronephrosis due to their obstructing tumor. And then we always, for all radiation patients, we're always asking about autoimmune diseases or prior radiation. Sometimes folks have had prior prostate radiation or brachytherapy, which really increases the risks with reirradiation to that area.
When you talk about autoimmune, you specifically inflammatory bowel disease, is that your major concern?
Inflammatory bowel disease, and so some of these we consider sort of relative contraindications, but inflammatory bowel disease, particularly if it's active and flaring, could be a risk with radiation. There's also patients with vasculitides or scleroderma that could be a particular risk for soft tissue necrosis after radiation. Yeah.
This is actually an important point in terms of chemotherapy selection because of the fact that with Gem-Cis Durva, you want to avoid patients who have autoimmune issues. And this will be the same situation with EV Pembro as well. So this is something you really need to get in history from the patient.
Yeah. Oh, sorry.
Oh, sorry. Yeah.
The point I was making was about autoimmune disease. And for those patients who you're evaluating for initial regimen, such as EV Pembro, or which is not yet approved yet, but Gem-Cis Durva or dose-dense MVAC, this is a selection factor for our patients.
Yeah, I'll say one consideration surgically as well when we think about urinary diversion for these patients that are going to cystectomy is really the renal function. So Most patients that have a cystectomy these days will have an ileal conduit, which is the most straightforward form of diversion with no real urinary dwell time. But in people who opt for a neobladder or a right colon pouch, we really do have to consider renal function. There's a major risk of acidosis in those patients. And obviously, platinum-based chemotherapy can impact renal function, but I think some of these immunotherapies can do the same. So we just have to be careful, I think, in who we're selecting for, at least we have to be careful for urinary diversion.
Let's move on.
Yeah, so just real quick on trimodal therapy, because then we'll move on to this patient getting cystectomy. But we know that T2 patients do better, and that's from pooled analyses of these early kind of phase 2 RTOG studies. And then, very importantly, patients need to have the visibly complete or safe, maximally safe TURBT, and some MGH data really shows there on the right that your survival outcomes really reach north of 60%, as opposed to much lower if you have a maximally complete TURBT. And then just a quick note that chemotherapy is necessary, and that was also from those early RTOG trials, but also I'll highlight the BC2001 trial, which was phase 3, comparing RT plus or minus chemo. And it was a 4-arm study because it was also comparing hypofractionated radiation versus conventionally fractionated. But we do see local regional disease-free survival much improved on the right with the addition of chemotherapy. And then finally, for the radiation portion, in the last 5 years, there's been some interest in more hypofractionated radiation courses. So in the BC2001, there was the 55 gray and 20 fractions, as opposed to more conventional 2 gray per fraction over 32 fractions. And it's at least non-inferior in terms of survival outcomes. It did suggest a possible local controlled benefit with the hypofractionated RT, which is interesting and may need to be studied more. But we are here at Yale offering hypofractionated radiation oftentimes for bladder cancer. Just a quick note that there are low rates of severe late GU and GI toxicity after trimodal therapy, also from MGH data, about 5% grade 3 GU toxicity. And those are, it's quite severe. Those are frequent hematuria. Cystoscopy might show severe generalized telangiectasias. And these are patients that maybe need to be managed with fulguration, hyperbaric oxygen, things like that. But luckily, that risk is low. And then you're probably asking, let's compare it to radical cystectomy. We do not have randomized data on this. There was a UK trial that did not accrue, but there's historical observational studies, of course, in differing populations, but roughly equivalent 5-year overall survival outcomes. And then I just want to make note of a more recent multi-institutional propensity score matched comparison. So they're really trying to mitigate the effect of any confounding variables, and showed similar cancer-specific survival at 5 years. And I wanted to highlight only a 13% cystectomy rate after trimodal therapy, which is improved compared to earlier studies, which suggested at least 20% patients needed cystectomy even after trimodal therapy for recurrence. So it's a good option, and I'll hand it over to Rob. Yeah.
All right, so I think, sorry. So just continuing on with the case, so this patient ultimately decides to proceed with cystectomy, and we've kind of covered this, but what is the optimal regimen for this patient? And just to kind of reiterate, I don't think that there is a definite best option. I think the Niagara study gives us another standard of care, not necessarily the standard of care, and that's for a couple of reasons, most of which Dr. Petrylak had already talked about in his talk. But the biggest problem is actually the control arm. The control arm got no immunotherapy, and we know that adjuvant immunotherapy, especially for high-risk patients after cystectomy, it is really substantial in terms of their outcomes. It almost doubles their disease-free survival. So can we say that IO chemo is better than chemo? Yes, but can we say that it's better than chemo followed by immunotherapy? No. So I do think that the other standard chemo regimens, DD-MVAC and GemCis, remain very relevant and options. And this just highlights the difference between DD-MVAC and GemCis. Sometimes they're considered equivalent, but we do have recent data from the Vesper study, which I just show here, that shows that there probably is some significant increase, at least in overall survival with DD-MVAC. Again, not a perfect study. These DD-MVAC patients actually got more chemo. They got 6 cycles instead of 4 in an attempt to normalize the time on chemotherapy. But it does look like that might actually be a superior regimen. So if we're adding IO, should we actually add it to an inferior regimen or a superior one? So there's some questions that are still up for grabs. And if you just go back 1 second.
Oh, sorry.
And then in terms of trying to isolate the effect of the neoadjuvant portion of Niagara, it's a little bit difficult because it was really perioperative. But if we do the very illegal but always very tempting cross-trial comparisons of just the Niagara study versus the Vesper, we see that there's not a huge difference in the rate of pathologic complete response in terms of the neoadjuvant regimens. And then if we continue, we say, okay, this patient ends up getting cystectomy, he does great, and he's actually found to have a pathologic complete response as well as negative ctDNA. And I think this is really the big question in the field is what do we do with these patients who we think are gonna do really well anyway? I'll say, the answer to this is kind of depends on what regimen you chose. So if you're following Niagara by the book, regardless of their cystectomy status, you would give adjuvant durvalumab. If we're trialing the more traditional chemotherapy up front, then it would actually be no, and we would wait. We would only give adjuvant therapy if there was muscle invasive disease. Now, I will say the better question is if this patient actually had residual muscle invasive disease but negative ctDNA, then what do we do in that case? And that's really not answered yet. But here I just highlight the modern study, which Dr. Petrylak also touched on, kind of using the ctDNA as not only prognostic but predictive. And I think this is really a great study that we have at Yale, but it's also kind of an example of kind of the next generation of bladder cancer studies.
And it's open at all the care centers, so you're welcome to participate in this.
Yeah, and it's very easy for patients as well. Yeah. And then just to kind of, I think we're short on time, but so the patient ends up completing durvalumab, and he or she does really well, and then years later is found to have a recurrence. So kind of what do we do in this situation? What is the standard of care? And I will say, I've been kind of wishy-washy on my answers before, but I think this one has a definite answer. It's EV Pembro. I think we know that EV Pembro is really an outstanding regimen, and then the new analysis that was just presented at ASCO by Dr. Petrylak kind of just reaffirms that. We know that 2/3 of patients with EV Pembro will respond, and 1/3 of those patients will have a complete response. We now know, based on the updated data, that those patients that have a complete response will maintain that complete response for over 2 years, 75% at 2 years, which is really unheard of considering the median overall survival for this disease was around a year and a half just a couple years ago. So I would say sometimes in ASCO is referred to as a victory lap for the GU regimens and for EV Pembro, and I would definitely agree with that. Yeah.
I think, Rob, the one point about this particular slide is the fact that will this patient actually need a checkpoint at that particular point? Because just single checkpoint alone, when we've tried re-inducing patients several years after they receive checkpoints, they generally don't respond. So either you believe that there's true synergy between EV and Pembro, which there's lab-based evidence to show that, or you just go with EV alone. But there is no right or wrong answer at this point. That's why we need the randomized trials.
I think that's all we had for slides, but obviously any questions we can.
Time for a few questions. Yes, Dr. Park. Oh, you've been waiting eagerly.
Could somebody please talk about infusion of tuberculosis bacteria into the bladder to treat bladder cancer?
BCG? Yeah. So usually used for always used for non-muscle invasive disease, localized bladder cancer. It's basically an option for trying to prevent recurrence in usually high-grade T1 tumors of the bladder. Series of washes given in the office, usually 6 cycles once a week. Did you have like a specific question about it or just what the regimen was? It's not in this patient population, it's not used at all, but for patients that have non-muscle invasive disease, especially high-grade disease, it's still the standard of care. Mm-hmm.
Okay, so I'm wondering about this space of neoadjuvant chemoimmunotherapy before for surgery, but also before chemoradiation. Is there any interest in looking at that approach for patients getting bladder who are hoping to spare their bladders to use neoadjuvant chemoimmunotherapy or any of these other kind of systemic agents or combinations?
Yeah, so I would say right now, standard of care is we would give neoadjuvant therapy just in the setting of an upcoming cystectomy. However, there is, I think, interest in seeing if that same approach works prior to radiation, knowing that there's probably some synergy between giving some immunotherapy right before radiation. But I would say it's not standard, but definitely something that is being looked at. Yeah.
Great, thank you.
Yeah. We are in SWOG, we are designing a trial of 3 cycles of neoadjuvant EV Pembro, followed by radiation therapy, and there's a second trial that's about to open that's looking at radiation therapy in those patients who have a clinical complete response after initial chemotherapy.
And will those be looking at ctDNA also? That would be very interesting, yeah.
Dan, there's precedent in oncology for giving the best therapy pre-op. Best therapy for metastatic bladder cancer at the moment is EV Pembro. I had a bladder cancer going for cystectomy. I want to know why you shouldn't give me EV Pembro. Is it safe?
That's a great question. I'll answer that in 3 different ways. Number 1, there are 2 trials that are about to mature. There's a trial called VOGA that is looking at EV durvalumab plus or minus a CTLA-4. At ESMO, we expect to see the data with cisplatin ineligible patients with EV Pembro compared to just simply cystectomy alone. That will open up the whole field in terms of giving EV Pembro preoperatively because that we lose about 30% of patients due to platinum eligibility. There's another trial that's looking at EV Pembro compared to standard of care chemotherapy that will mature later. The answer is...
Trials closed early.
Excuse me?
Any closed early?
They've not closed early. The issue with EV Pembro is the neuropathy. So the data that I presented about 2 years ago looking at EV Pembro, EV by itself, 3 cycles of EV followed by cystectomy showed that we had about a 25% rate of peripheral neuropathy. So that's a problem. And the question is, which patients do need it? And that's something we need to look at biologically. The fascinating thing is that the most aggressive form of urothelial carcinoma, the plasmacytoid variant, has the highest expression of Nectin-4, and we've seen several pathological complete responses in studies with that particular drug. It will supplant it. We just don't have the data right now. Would I personally do it? I would.
Who's that? Pat? Should we let Pat LaRusso ask a question? Okay, let me run back here.
All right.
Okay, hold on. I'm doing my best here.
Okay.
So we know that there's been some ADCs that have not been able to be successful given systemically for bladder cancer, even though they were very effective preclinically in preliminary clinical trials. And we know that BCG, especially if you're a male, it's not the most convenient drug to give in non-invasive bladder cancer. So we do know that there's clinical trials ongoing instilling the ADCs that were extremely potent, extremely effective, but very toxic into the bladder with some preliminary very positive results, which number 1, binds to the receptor, number 2, does not have to be given as frequently, and number 3, is devoid of systemic toxicities. Can you comment on that at all?
So there have been some preliminary studies with EV, but I have not seen any published data with that at this point. It's not been presented. I've been disappointed that we haven't seen that yet. Now, it may be a different situation biologically. We have recently had some other drug approvals in the non-muscle invasive state, namely the TAR-200, that is a unique way of using a pretzel, which you insert into the bladder, that gives a continuous dose of gemcitabine over 2 weeks. And perhaps that will be a less invasive way of, rather than sitting for hours with a catheter in place, just simply inserting this particular pretzel. And this also has the advantage of delivering drugs such as the FGFR3 inhibitors, which have significant systemic toxicity. But as far as the ADCs go, given intravesically, I've not yet seen EV or sacituzumab being presented at any major meetings at this point. So I'm not aware of that. And again, it's disappointing we haven't seen this yet because I know those trials have been going on for several years.
Okay, that was great, and thank you to the panel. We appreciate it.